This panel today will feature Carrie Stoltzfus, Executive Director of Food and Friends, Dr. Morgan Medlock, Director of Comprehensive Psychiatric Emergency Program at the Department of Behavioral Health, Dr. Yavar Moghimi, Medical Director of Behavioral Health at AmeriHealth Caritas, and Chanelle Rollins, Director of Clinical Services at the Psychiatric Institute of Washington. In addition, Tricia Quinn, Director of Policy and External Affairs at the DC Primary Care Association, will moderate our panel. Tricia, I'm happy to turn it over to you.
Thank you, Gail. And let me get to my slides. I'm going to do a little bit of queuing up of our conversation ahead of really hearing from all of our panelists. So thank you again to DCHA for allowing me and for the panel to be part of this amazing summit. And thank you for centering racial equity. As Gail mentioned, I think it gives us the chance in the context of this panel on social determinants of health to draw the distinction between structural determinants of health and health-related social needs. About 4 years ago, DCPCA started facilitating a coalition on social determinants of health that includes a range of clinical care partners, of social support organizations, of other health system leaders, and of government partners called DCPACT. And what you're seeing on your screen now is the framework that PACT has adopted in terms of our work together. This recognizes the need to address immediate social needs like housing, like food security, social connection, transportation, as well as root cause inequity, such as impacts of racism, environmental, economic opportunity. My colleagues on the panel are doing important work across this spectrum and work in both spaces, although the pathway perhaps around health-related social need is somewhat more clear for all of us. So we've consistently, as a society, been considerably more comfortable supporting and spending money on healthcare than on anything else that contributes to health, even when the data and the research tells us that other things might matter more than healthcare. By now, most of us are familiar with the idea that our health is impacted only about 20% by the clinical care that we receive. Yet our bias is overwhelming investment still in that 20%. You can see here, compared to other developed nations, the US spends significantly more on healthcare expenditures and considerably less on social supports than other wealthy nations. And in fact, we end up more or less in the middle of the pack on combined spending. And that would be fine, you know, 6 of one, half a dozen of the other, if our outcomes were as good. But they are not as good. And you can see on this chart, the life expectancy in the US falls considerably below many of those other nations. And when you look at, I apologize, this slide is a bit of a blur, but when you look at how life expectancy shakes out in health system rich Washington, DC, the story is somewhat similar. Lots of investment in healthcare. For example, 97% of residents in the district are insured, but still lots of inequity. The life expectancy in predominantly white Ward 3 is 87.6 years, and in predominantly Black Ward 8, it's 72. So I find myself really asking the question, why has our system evolved to spend on healthcare so much more money than on social support or on economic equity? One answer is racism. Does the bias to invest in the health system spring from who benefits the most from that spending, the business of healthcare is overwhelmingly white, versus who benefits when we invest in basic human needs, or even more when we invest in things like universal basic income. How can the health system, the health sector, engage in addressing health-related social needs, what our DCPAC coalition calls downstream approaches, but also participate in transferring resources and power to the social sector, or even more importantly, directly to communities? We have a wonderful opportunity to learn from the leaders in the district on this panel who are grappling with both these questions, innovating, collaborating, and pushing past the boundaries that box people into being only patients. I admire them all immensely. I know from conversations we've already had that this will be a rich dialogue, and I look forward to the exploration of these questions together. So welcome, panel. I'm so glad to see your faces again and be together to have this conversation. So I think we decided to start by basically asking each of you to kind of share with us, in thinking about that spectrum of structural determinants of health and across through health-related social needs, where do you think your organization is on that spectrum, and what are you currently doing? And we're going to give the floor first to Carrie as from Food and Friends to kind of share your perspective on that.
Great. Hi, can you hear me?
We can.
Wonderful.
Wonderfully.
Yeah, thank you for having me this morning. So let me center that question by just talking a little bit about what Food and Friends does. So we are a medically tailored meal organization. So when someone is living with a serious illness, be it cancer, HIV and AIDS, diabetes, heart failure, kidney failure, or a number of things in combination with each other, their healthcare provider will refer them to Food and Friends, and we provide nutrition at no charge to them and their household, and we deliver it to them at home. So they're getting food that's designed to meet their health needs, whatever stage of whatever illness they happen to be living with, and we help them navigate their health at home. So in that sense, we're making this individual intervention really on a door-by-door basis. But it then also has those upstream effects. So we're meeting those social needs. We are a number of our clients, the majority of our clients live in areas where nutritious food is harder to come by. But we're bypassing those systems of inequity and taking the food to people there at their door and addressing it on an individual basis. But then what that does, in the broader community and in a more systemic sense is it reduces chronic stress, it lowers healthcare costs for those patients. They're more likely to adhere to medication and maintain, their regular care with their healthcare provider. So it's got an effect both on the individual and more the systemic level, but we are intervening on a person by person basis and giving them individualized care.
I think you make a good point that it's not always a solid line, between addressing health-related social needs directly and how are we potentially impacting some of the structures that contribute to those inequities. I appreciate that. Chanelle, can you share from PIW's perspective, where do you see yourselves in the work on that spectrum, and what are you currently doing?
Sure, absolutely. Thank you all for having me. I really do appreciate it. And I'm honored to be among such revered colleagues here. PIW is a short-term acute care setting. We try to be a resource for everyone in the community. We accept walk-ins as well as referrals from community service agencies, ERs, and we do have a large FD12 population as well. We currently have a dedicated COVID positive unit and have done our best to really free up those local ERs by accepting those COVID plus psych patients to allow for the ER's flow of patients to go a little bit more smoothly. In addressing the social determinants of health, it is important work. On an individual level, we are a bit limited here because we are a short-term acute care hospital setting. However, on the larger scale, we do really try to work with our community agencies to identify those barriers to services out in the community and closing the gaps in services when people are being discharged from our service back into the community to really attempt to address the recidivism and ensure that those individuals are able to safely maintain themselves in the community. There have been, a lot of challenges during this time, which I know we'll get into a little bit later, but we really do try to work with our community agencies and partners in addressing these gaps and kind of closing them up a little bit as much as we can.
Thank you. Thank you. Dr. Medlock, Morgan, from DBH's perspective, how do you think about this spectrum and the work that DBH does around social need?
Well, the system as a whole, and good afternoon to everyone. It's great to be here. The system as a whole has taken on a strategic vision of moving toward hope and healing, and so as an entire agency, we are both direct care providers, which of course is a downstream intervention, but we are upstream informed in that we recognize that partnerships with agencies that are thinking about policies and structural issues are critical for us to truly bring hope and healing to the community. As you know, I am the director of the Comprehensive Psychiatric Emergency Program, which is certainly a downstream crisis mitigation center. However, we have also taken seriously the impact of root causes on crises and thinking broadly about what recovery and resiliency mean and what support to communities that we serve really looks like at the point of crisis. So we do more than simply mitigate symptoms. We actually do think with each of our patients about what system navigation, process navigation, and other determinants of health have to be addressed for them truly to recover and to do well from a mental health standpoint. When I think about just how I bring this all together as a psychiatrist and as a crisis provider, I think about the fact that root causes and societal institutions and structural determinants act upon socioeconomic status, race, and other social strata, which in turn impact someone's psychological coping and responses, which in turn then affect their own mental health and physical health. And so the differences that we're seeing downstream, the disparities, if you will, are actually rooted in inequities. And that's kind of how I think about the whole issue. So yes, I represent a downstream agency, but we cannot help but be upstream informed.
And even as you described it, hope and healing, was that what you? The phrase you use, hope and healing.
Yes.
Which I love. That hope and healing framework applies to our city writ large, our communities, as much as to individuals who are experiencing the crises that you're sort of charged to address in the immediate. So Dr. Moghimi, Yavar from AmeriHealth, can you share with us a bit your thinking about this and what AmeriHealth is working on now?
Sure. Thank you, Tricia, for bringing together this panel, and happy to share and work with all our panelists here on joint efforts on improving SDOH in the city here. So, and I like the way you created in this spectrum of the downstream health-related social needs and the structural parts, because I think there is, in my mind, a role for us to play in each part of that spectrum. And as you mentioned, I think it's a much clearer path in the downstream social needs part of it. And so, doing SDOH screening has been an embedded part of our case management for years now, really following kind of the prepare model that is used in a lot of FQHCs as well. And using those different areas where we're screening to make appropriate referrals using a referral platform that we have contracted with and that we try to build a network of resources through. Moving to the point where we can get to a kind of bi-directional referral pathway in place if that's happening internally with our MCO case management. We recognize that, you know, there's only a subset of folks that are in our case management, and most folks are more connected with their providers and what the providers are doing. So we've tried to incentivize providers through our value-based programming to use SDOH Z codes as a part of their billing process, you know, and figuring out, and through working with DCPACT, obviously, as we're trying to standardize the SDOH screening and codes we're using, we want to have alignment so that, you know, if providers are taking the effort to do the screening and to make the referrals, that they're getting recognized for that work beyond just the billable. Of course, there's specific interventions that we've really decided to adopt as sort of value-added benefits for our members. You know, we work very closely with Carrie and Food and Friends for food as medicine approach based on condition, based on hospital discharge. We work with 2 different transitional housing providers for some of our members that are really having a tough time staying out of the hospital, either on the behavioral health side or the medical respite side. We recognize that there's a pretty big disconnect between the homeless management information system and the Medicaid world. So we've partnered with Pathways to Housing to try to get our folks who are homeless more connected to housing, and also working very closely with Children's Law Center on folks that need specific advocacy around their healthy housing issues. So, I mean, in some ways, these are all health-related social needs, but I think what we're trying to be a part of the larger discussion too. So, you know, through my participation with DCPACT and the connection with the Ward 8 Community Economic Development Group, we're trying to be in the discussion to around the city's planning efforts and making sure that health equity is embedded in the planning efforts of the city. So again, it's a less clear path than what I was previously talking about, but I think a very important path to be a part of.
And you named and brought up a lot of partnerships, and I think without a doubt we have all acknowledged, like, that is the only way that this vision around, you know, really helping communities get and stay well happens, right? That it isn't the job of any one, certainly not any one organization or any one sector, and that there's some technical aspects to this too, like how do we do it? And I have been grateful for the folks on this panel, like your willingness to engage in the what is the health system's role in that larger structural inequity conversation, and that we have work to do to figure out what that is, and hopefully through this conversation some of that will emerge. So in particular, when you think about challenges in addressing your population's social needs, the district's social needs that impact health, you know, what do you identify first? And I won't be surprised if in answering that, a lot of structural things kind of emerge. But Yavar, maybe you could start from AmeriHealth's perspective. What are the most significant challenges?
Yeah, I mean, I think I can speak to a very timely issue right now where you're seeing with the new contract changes, there's a huge shifting of membership happening, right? Which, you know, it's understandable that this change would happen. At the same time, it's when we're sort of investing time and energy in our members' health and trying to address all these social determinants, acknowledging that at some point in time, this person may not be our member anymore. And, you know, you invest this money and time and energy in improving their health. And ultimately, we may not be the ones that would see the benefit of it. So I think that's a real challenge as a health plan because of that. And ideally, you have folks that graduate and come out of your health plan because they're no longer on Medicaid anymore either, which again is a good outcome. But ultimately, the benefits of that are being seen by maybe the other health plans. So
you are bringing up something very important. That
right,
wrong pocket
right. So
problem.
you know, we try to exactly. So yeah, I think that's I'll leave that for my point there.
Yeah, I didn't mean to interrupt, just that we didn't really talk about this ahead of time, but just the way in which that wrong pocket problem plays into, and by that we mean like who pays for the intervention, who invests in the improvements may not be necessarily you see the return on that if we want to kind of monetize a bit. And we have to address that in the long haul. And I don't think the sector has fully figured this out. You know, how do we address that? So thank you, Yavar. Morgan, what do you see as the biggest challenges in this work around social need?
I want to actually just point to what I think summarizes the damage that is done when we talk about structural violence and the perpetuation of what I term a legacy of exclusion. In that the communities that we're trying to serve are often excluded from the process of engagement, so that the transformation can take place and inequities can be removed and barriers can be broken down and we can really move to hope and healing. That, for instance, when we look at housing in DC and the legacy of displacement, and so why is it that often communities feel that the changes that are happening, in fact, again, perpetuate this legacy of exclusion? There are changes that are for someone, but communities that have been here feel that it's frankly not for them. And so again, as we are trying to create an ideal healthcare system, I do want to point to the critical role of community engagement in order for us to combat, again, the damaging legacy of exclusion.
Yeah, and how often do we think about that community engagement as SDOH work? You know, it is. And I think you're exactly right. How do we, and that's part of what I wanted to convey in the opening. Like, it's not just meeting health-related social needs, it's ceding power to communities. That's social determinants of health work. You know, I appreciate that. Thank you. Chanelle, challenges. What is PIW confronting?
Yeah, I really want to echo what Morgan had mentioned. You know, that kind of sense of belonging or being excluded from and not really having that place and not feeling that people's voices are heard. Definitely a challenge. I kind of want to focus in and narrow down a little bit more. I think especially in this time, you know, they're specific to COVID, but you know, it could really extend across. A lot of agencies didn't have clear policies or procedures in how to continue their services, continue their sense of normalcy during a time like this. And, you know, there were some partnerships that we had to kind of rework and get really creative with on how to address some of these needs and services. Housing was a really big one. You know, we have a very large population of homeless patients that we have. And, you know, we had these partnerships where we were really easily able to discharge and have them wrapped up in these services. And we didn't see them quite as often. But during these times, I think those partnerships really had to be rebuilt and reworked and really get a sense of how to address the needs in the community during these changing times. I do recognize that, you know, a lot of policies and procedures that we also put in place kind of, I don't want to say contributed, but really made things a little bit harder, and we had to get more creative in how to really engage the community and make sure that our patients, once they left us, were still connected. And, you know, their needs were being addressed, their care points were being done. We really tried to be sensitive to outpatient providers needing to still continue on with their services and understanding that sometimes when they were here with us in the hospital, that was the time that their outpatient provider really could get in touch with their patient or their client, because once their client was out in the community, for whatever reason, they had a really hard time getting in touch with that client and providing those needed services. And it wasn't that the client, necessarily was trying to be non-compliant or anything like that, but it was really just that technological issue. And I think in the time of COVID, that really made things a little bit more difficult. And we really had to get creative on how we were addressing a lot of these service gaps and still making sure that we were providing services to our communities.
Yeah, I think we're going to dive in a bit to what the arrival of COVID has meant in the space around health-related social needs and how it might have changed, for the future, how we think about and act on these issues. Carrie, can you share for Food and Friends what you kind of frame as the biggest challenges for your work?
Yeah, I think, the challenge that Yavar was talking about also has an effect on Food and Friends and agencies like ours, community-based organizations that are addressing the social determinants of health. These are long-term impacts. Changing the nutrition that's available to someone takes time for those results to show up in their health. So when I am promoting Food and Friends and the idea of nutrition as something that's worthy of partnership and worthy of investment, it's tough to make that argument if the agency that is working with us, their patients may change, or someone might see another doctor, they get a new health plan, and they don't see the results of their own investment. And it really does take the first person to dive in and make that investment. And in regards to the Medicaid community in DC, that really was AmeriHealth. And so I do want to call you out and your leadership, Karen Dale specifically, her take was, it's the right thing to do, so I'm going to do it. And then once she did that, it was so much easier for us to have those other conversations with other agencies and build a system where now anyone, who is a Medicaid recipient in the district has the option of receiving meals at home. And that's fantastic. But it does take that first investment, and that's a pretty tough decision to make.
Yeah. And if we could get to the place where we all committed in the same ways to what we want to build in the city, and with and for the people who are here now, to Morgan's point, that maybe we eliminate or mitigate the wrong pocket problem in some way. So turning to COVID, because I think in so many ways COVID amplified so many of the issues that we're talking about today, but perhaps maybe also through that amplification provides a new opportunity in some ways. How do you think COVID will change or has changed the conversation around addressing social needs in the communities where you all are working? Morgan, could you start? What has the current environment in public health and around COVID meant to how we think and act on these issues around social need and structural determinants of health?
Well, I think the pandemic has really revealed the emergency nature of many issues in America, including racism. And in fact, many public health leaders are calling for racism in itself to be declared a national emergency because the pandemic has really unveiled and made clear the relationship between racism, inequities, and then health outcomes. We were on a webinar yesterday, and I mentioned there that the risk factor is not race, it is racism. It is how systems in America act upon social status. It is not simply the fact that someone is African American that they're more likely to die of COVID-19. It is the fact that they are more likely to have jobs where they are at higher risk of exposure to the virus, or the fact that they are at higher risk of housing insecurity and therefore cannot shelter in place. It is these larger structural issues that were really exposed as a result of the pandemic. And so the tragedy of that has been that it has elevated the conversation. It has given a larger platform for us to realize the importance of things such as universal health care and other issues that have historically been political conversations. Now, all of a sudden, we're recognizing that, no, this is just a basic dignity issue. This is just a fact that in order for communities across America to be well, there are some basic structural and policy issues that have to be addressed. So in that regard, it's sad that it took a global pandemic to really make this so clear to us. But I think that has been what we have really taken from COVID-19. As you know, the data is startling, especially when you look at cities across America, where in some cases it was reported that in populations where it was only 30% minority populations, it was 70% of the COVID-19 deaths. And so obviously the data needs to be refined, but this has truly shown us the emergency nature of racism in itself. Speaking from a mental health standpoint, I can tell you that the latest surveys have revealed that in the context of the pandemic, over half of Americans have endorsed significant anxiety. Around 36% have endorsed significant insomnia during the pandemic. A significant amount are worrying about the economic recession. And just imagine if you're in a condition where you don't even have a job to worry about, that you were already, even pre-pandemic, in a state of emergency. And so for a lot of the communities that we're talking about, COVID-19 was a superimposed crisis. It was not the crisis. And so often, as we're engaging with individuals here at CPEP and in the Department of Behavioral Health, their mental health issue and the other structural issues that they're dealing with were the crisis. And now we're trying to also help them maintain in a pandemic. So to summarize, we have developed a new way of providing care through telehealth, telemedicine, telepsychiatry to maintain health for the 30,000 lives that we are responsible for here at DBH.
I think the exposure that you describe in terms of the overlay of racism and what it exposed through COVID has, even for people who maybe philosophically were not in the space of acknowledging racism, or if they acknowledged it, whether they cared about it, it has public health implications. So I think it does open up, like, who needs to care about the structural determinant of racism? It turns out we all do, no matter where we are in our own sort of philosophical approach to that question, because it has public health implications. And then, one thing that has come up that I think we might want to explore, if not in this panel down the line, is the explosion of mutual aid and mutual aid sort of endeavors that went outside of some of the organizational structures that all of us are part of, to find ways for communities to band together and help each other. And down the line, I think that is going to be worth really understanding, and then figuring out, perhaps, how does the health system invest in that? Like, to your point, Yavar, about partnerships and the different partnerships. And in fact, I think there was a question in the chat that somebody asked about partnerships between providers. Are there other stakeholders who should be part of the conversation? Friends, neighbors, DC residents. Have any of you engaged with any of the mutual aid efforts at all? Yeah, it's not our forte, right? Like we have our structures and our systems, but I think it's probably something to consider. Yavar, you were coming off mute. Did you want to add something?
Well, I wanted to build on what Morgan was saying, also just about the impacts of COVID-19 as well on how it also allows for changes that maybe prior to this were not considered possible or feasible. And I can give one good example of, we know our homeless population in DC has a lot of comorbidities, both physical health, behavioral health, and that really the shelters for many of them are just not a healthy living option, and I think COVID really highlighted that because of the risk of COVID, but also they're a medically vulnerable population. And so, I mean, I think through Department of Human Services leadership, they recognized that in addition to needing quarantine hotels, that they actually needed to create a program for medically vulnerable individuals, the PEP-V facility, they call it. And this is sort of a new option for us to really work with, pathways to housing and identifying medical vulnerability as a real risk for that these people are homelessness and medical vulnerability these don't work well together. So we have to it provided a new space that didn't exist previously, which I think is now sort of becoming a pathway towards more permanent housing as well. So there is when you reach these sort of pressure points, you see the system kind of bending in a way that I think that's something that probably it should have done for a long time.
Right. The innovations that seemed out of reach are not. And I would urge us as health system actors to think about that in the social needs space, like things we thought were like, nobody's going to do that, or that isn't in our frame. What we learned from COVID, certainly on the telehealth, is that the health system can change quick, and if we decide as a health system that addressing social needs is part of what we need to do, then we can innovate and test and try quickly and learn from our errors quickly and iterate. It is about that push and that will, and that we could go there. So let's talk about that a little bit. I'm not sure, where are we in time? Well, we're doing all right. Let's talk about that a little bit around, do we believe that the health system can effectively do this work with the equity framework in mind, to Morgan's point of like, not to communities, not for communities, but with communities? What can we do that? Do we have a track record? Can we be trusted? Who wants to start on that one? I could pick on somebody, but it's a juicy morsel. Can we do this work with equity in mind, in partnership with communities?
Well, this is Morgan. One of the things that I think we do have to grapple with in healthcare is our fidelity to a marketplace model for providing services. If we truly are going to take a capitalistic stance and focus on profit, then what is the incentive to assist vulnerable communities who have nothing to contribute to the marketplace? Mm-hmm. At least from a capitalistic perspective, right? If we're looking at it from a purely economic perspective, what about a capitalistic model would promote the types of partnerships that we're talking about with communities who have been totally disenfranchised? And I'm not saying that those communities do not have strengths. They absolutely have strengths. What I'm saying is that there have been intentional actions to drain the resources of those communities. And so if the actions to deplete those communities were intentional, then the actions to restore those communities have to be just as intentional. But what I'm also saying is that I do not see, with the current model of healthcare, and in particular the economic drivers of healthcare, how we do the intentional work of rebuilding communities without setting a whole new frame for healthcare, not purely as a profit-driven industry, but a service industry. And I think it's going to take some reframing of the entire system, from who we select for medical school to who we select to be CEOs of hospitals. We're going to have to shift the entire system so that we're not just focused on a profit model, but on truly a service and community engagement model. And I think that's such a powerful shift. I do wonder if we're ready for that.
We're willing. I think that's I think it was in a recent Health Affairs, a similar sort of response to, can we trust us, the health system, to do this, and what evidence do we have, you know, and that some of our sort of like addressing health related social needs, that's a little more comfortable a space, because there is some return, right? If we lower the, you know, we feed somebody better, if we house them better, then they cost us less. But for those structural elements that require massive shift, you know, where are we? Anybody else on this point? Yavar or Carrie, you jump in?
Yeah, I mean, I really like what you said, Morgan, about healthcare as a service industry. And I do think it really is going to take a systemic change, you know, just across the board, top to bottom, a lot of time. Really, it all does have to change. There are great things we can do on a more micro scale. And I just want to talk about an example of one of those that we're doing at Food and Friends. Is we have partnerships with the local medical schools, specifically with Georgetown and George Washington, and medical students come to Food and Friends, or at least they did pre-COVID. We're going to get this program back up and running. But they don't only learn about nutrition, but they go out and deliver meals in the neighborhoods and see their future patients and where they live and talk to them directly face to face. And there's not a lot of home visiting opportunity in the traditional model as we have it right now. So we provide that to them and just try to help them, you know, get a better sense of what their patients are dealing with in their communities and in their lives. And I think that's a really positive thing, you know, but we're doing that, you know, really one cohort at a time, you know, one group of first-year medical students at a time. It's a powerful program and we love it. And that's one of the tools that are part of a much larger systemic change that needs to happen.
And let's try to get all of those med students to stay in the district, right?
Yes.
So that, I mean, I want other people to have the health systems they deserve too, but you know, this is our space. Yavar, did you want to jump in? Thank you, Carrie.
Well, I just wanted to cite that I think there are some examples of health systems taking a larger structural approach to making change. And I mean, since this is a DCHA meeting, you know, I think highlighting that hospitals are anchor institutions in their communities. Yeah. And as a result of that, you know, there is the community benefit part of that relationship for nonprofit hospitals, where you know, some hospital systems have taken that and run with it in a much more structural approach. Like I think probably the best example is the nationwide, the Children's Hospital in Columbus, Ohio, that, you know, invested a lot in you know, using the same kind of health equity map that you looked at before, really identified that their sickest patients and families were coming from a specific neighborhood that, you know, had a lot of social determinant issues, and they really heavily invested in that community. And also, hospitals are also one of the major employers in cities, you know, and so created a pathway also for more stable employment for folks from that neighborhood to actually be employed by the health system too. So addressing kind of multiple issues at the same time. So, you know, I think it's early to see these kinds of models, and I think people are trying to see how they're unfolding, but there's clearly a pathway, I think, for like creating more pressure for anchor institutions
kinds of
to
investments.
truly, represent their communities and do, what they can within their bounds to actually make an impact.
I want to be part of Dr. Medlock's revolution she was just starting there for right now, but acknowledging that there is these big system questions about commitment to approaches in the health system writ large in our country, and that those conversations are happening at a political level, at an economic level. I guess my question is, and Yavar maybe partially answered this, what can we do on a local level, because we aren't in charge of all of those things? What can we do on a local level that gets us in that space of, this is what I love about DC. You can know everyone you need to know, whose mind you need to change to get the thing you want done. How do we change what we do here, even if we can't necessarily change everything? What are our thoughts about that? And maybe community benefit is one place to begin. One thing I keep kind of coming back to in that is the Department of Healthcare Finance provides resources for health insurance for, I want to say it's, upwards of 270,000 district residents. That's a significant proportion of the district residents, way more of a proportion than any state has, resource. And what's the opportunity there? I don't know. I'm throwing a lot of spaghetti on the wall right now. Thoughts, anyone, in response to that or other big ideas?
I think we have to look outside of just healthcare finance and really look at, most folks who are who would most benefit from the social determinants supports that we're talking about are engaged in multiple systems and agencies, right? So there's I think there's a data problem and the wrong pocket problem too that you talked about, where, all of these folks are not necessarily collaborating on the same level that they could be, that would really be hopefully addressing some of that duplication or some of that, like, how do we ultimately all benefit from this? And I know in other, I think some models of trying to do that are doing things like a global capitated rate for like multi-systemic agencies, looking at things like that. So DC is small enough and I think nimble enough where, it's still a bureaucracy, but I think we have the wherewithal to try to move in that direction that I think would ultimately, the part of what you have to do all of this with human-centered design in mind, and that's to the person's question earlier about, who should be involved in this. Like, if you don't have the end user of all of these services involved in this whole process, then you're going to create a system that ultimately still doesn't work for them because you didn't really get their input throughout the way. So
yeah, I think that's fantastic. We've been running an equity action lab on maternal health. DC needs an equity action lab on addressing health-related social need, at least in that smaller box. And what we would learn from that would be incredibly exciting.
Sorry, I just want to add something, tag on there about data and information sharing. I think we're all, part of one larger system, but slightly siloed in what we're doing as well. And we're all really sitting on a wealth of data and information. And if we can somehow figure out how to really share all of this and analyze it together and get that input from the consumers, I think that is what's really going to make the biggest difference. Because as Yavar was saying, if you don't have the end user or the person benefiting from it at the end involved in the process, your buy-in is really not going to be there. And we need that as well from our communities and other systems, other agencies. And I really think that data gathering and information sharing is huge. And we really have to figure out a way to get everyone on the same page, because we're all working towards, one goal, and we all really need to kind of get on it together.
Mm-hmm. I couldn't agree with that more. I mean, what I always think about is, for our clients, their privacy and their time. If I'm asking them questions that someone else was asking them yesterday, how am I going to get that buy-in and build that trust with them, to partner with them in their health? And so that's not my area of expertise, but I would love to be a part of any project that's working on, helping us do that better.
Yeah, and there was a question in the chat about specifically, like, how do we get feedback from community members? We might feel like, wow, there's a lot of programs out there, but is that what the community recognizes as its own need and want? And to the data point, lots of data, but does the community interpret that data, or do we interpret that data, or are we in partnership in interpreting that data? Has anybody done work that you've started to think about how you directly have the community drive your social determinants work specifically, as opposed to any way else you might develop programs?
Well, I can speak to, the work we were doing at Howard, and even after my transition to DBH, I of course maintain affiliation at Howard. And one of the things that we were specifically doing is thinking about how community engagement and addressing the social needs of specifically Ward 7 and 8 residents would then promote equity in addiction medicine. That is really what we were trying to think about. And just for the background of those listening, the inequities that we know about in all areas of medicine are pervasive when it comes to addiction medicine as well. Where we know that specifically African Americans are 47% less likely to be prescribed evidence-based treatments for opioid issues and other substance use issues. And so what we were trying to do is engage the communities in Ward 7 and 8. As we know, we could talk all day about how that community has been excluded from change in Washington, D.C. But what we found as we had focus groups and roundtables with the community is the first thing is when we really when we talk about power and thinking about how research and data are managed, the first thing that occurred when we really shared and shared the authority with our community members is they quickly let us know that the priorities that we had were not what was on their mind at all. That this so-called focus on bringing evidence-based treatment and what that even means to the community, they were thinking, well, let's first deal with wealth inequality in Ward 7 and 8. Let's first deal with what our community boards and neighborhood commissioners are thinking about in terms of our economic investment policies here. And it was really sobering, no pun intended, to think about the fact that here we were thinking that the solution was medication and medication-assisted treatment and all of the things that yes, from a scientific standpoint, are life-saving. And the community is saying, wait a minute, we want to talk about economic issues. We want to talk about racial trauma. We want to talk about the fact that addiction in itself is downstream to all of the other legacies of oppression that have been enacted upon us as a community. And so I tell you that working with the community board in Ward 7 and 8 was really eye-opening. It really let me know that our entire agenda will need to shift when we really engage and involve the community.
And to that point, and Yavar's point of hospitals as anchor institutions, here is one place where the health system could have direct impact on economic opportunity in the communities where we are, where we're serving patients. And I think Elizabeth had a question about, like, how do we support the workforce to look like the people who are being served by those institutions, and how do we provide the right supports within that workforce so that people can get and keep those jobs? Like, that's social determinants of health work too. And how well are we doing in our industry in supporting a development of a diverse workforce that speaks to and comes from and lives in the communities that we purport to care so much about? You know?
And I think you brought this up before about, the Carrie's program with training the med students and having them involved in those programs. How do we then keep those med students here in the city? Similarly, with all of our staff, our social workers, our floor staff, our nurses, everybody, how do we get them in the door, make it enticing for them to work with our populations, but then also support them so they don't get burnt out and they don't leave? Because it is a very difficult place to work, and the populations can be difficult, but how do we keep people motivated and really reinforce that sense of community? Because, a lot of people from DC are from here, but then they get their educations and they leave. And how do we prevent that from happening? How do we make them want to work in the city and keep them safe also? Because I think the burnout rates are really high, and the vicarious trauma is really, prevalent, and we really need to address those things from various avenues to really shore it up and make it so that people can be successful in the communities that they come from.
So thank you, Chanelle. I think that this is a place where the health system should collaborate more. How do we collectively approach this challenge of workforce? Because I know from the health center perspective, it's a huge struggle to hire and keep people. And how do we address this from a structural determinants perspective? And put a flag down with communities in some specific ways. A question came in about specifically in the district, like, is there prominent social need here that we would want to address? Is there sort of a hierarchy of how to address social need? Must you do X before you get to Y? Morgan, you were sort of hinting at this, like you had an idea of what the prominent, like, must do thing was, and the community had a different perspective. Does anyone else have a thought about that? Like, is there something that has to come first that we do collectively? And I guess I would ask this of us as part of the health system. Is there something the health system should do first? Precursor to other things?
I answered this in the chat as well, but I do think you run the risk, if you're trying to address everything at once, that you're not going to always, make the impact that you want. So, I do think there is a value in being laser focused on, especially if this is a new space for the health system to be addressing, social factors. And I think part of our approach, Tricia and DC PACT, I think, has recognized that, like, what's the lowest hanging fruit here to start out with? And I think we recognize, for example, food insecurity. There is this food as medicine movement right now. There's already good outcomes that we're seeing with that. There's a national movement towards really standardizing what food insecurity looks like, in a way that we're all using the same language. And maybe even though there is a long-term, even though Carrie was saying there's a long-term impact from this change, in some ways it's an initial step, easier to address than probably our affordable housing crisis in the city, which is a much tougher pill to swallow. Not to say that we shouldn't still be screening and trying to assess and understanding people's housing situations, but again, you run the risk of if you're screening for something that you're not able to actively address, then is that just a re-traumatizing type of situation too? So
Yeah.
I think for us to prove to the naysayers about, because there are a lot of naysayers out there that SDOH should not be a priority of the health system, and so I think we have to be able to still show that we're making an impact on this work.
Yeah, and I will say, I know Gail's going to tell us our time is up any second, but I will say, so the district has included this as part of what they want the Medicaid MCOs to screen and address. The district has invested into Chanelle's point of like data, and we're all sitting on a lot of data, trying very hard to invest in through CRISP, a data system that would allow us to see what we know can help our patients across systems, even beyond healthcare, through some of the SDOH work that DHCF is funding CRISP to do. So I feel like we have a little think tank growing, and I think DCHA and DCPCA should put our heads together on, this ongoing dialogue around health system role in this space, because you guys are amazing, not only thought leaders, but actors in this space. And I thank you for everything that you're doing.
Thanks. And I actually hate to cut the conversation off, because I didn't have my video on, so I didn't distract everybody, but there were several points where you were talking about things and I was like, oh, this is in progress. And we were thinking about that. So I think we're keenly interested, part of why we chose this topic today. And I think, if we could, people do this, we could have a whole session, a day full of social determinants of health conversation. And I think many of us would not be bored at all. In fact, we'd be inspired. So I do want to thank all of you for sharing your thoughts on this. Such a diverse set of roles throughout the city, I think really helps get a better picture of sort of how we might approach this going forward, and what the challenges are, and what we might need to do to address them. So I just wanted to take a moment to say thank you so much for joining us today. That said, we're going to do a brief transition to our awards presentation.